To access the ASV graph, tap the middle of the screen, select the Graphics tab, and then choose ASV Graph. The vertical axis represents tidal volume, and the horizontal axis represents the respiratory rate. The curved blue line represents all the combinations of tidal volume and respiratory rate that result in the target minute ventilation, based on the calculated ideal body weight. A red box on the ASV graph represents the ASV safety window. Inside the ASV safety window, a green target represents the optimal tidal volume and respiratory rate combination. The yellow cross represents the patient's actual values. ASV adapts to the patient's breathing mechanics, spontaneous activity, and tidal volume to bring the yellow cross and the blue circle together, indicating optimized ventilation for the patient. The red safety window dynamically adjusts to the patient's breathing mechanics too. A wide square-shaped safety window with an expiratory time constant between 0.5 and 0.7 indicates healthy lung mechanics. A long expiratory time constant, greater than 0.70, produces a narrow and high safety window, which signifies increased resistance from COPD, asthma, bronchospasm, and endotracheal tube obstruction. A short expiratory time constant, less than 0.50, indicates decreased compliance due to the lung or chest wall caused by ARDS, lung fibrosis, kyphoscoliosis, and elevated abdominal pressure. If the expiratory time constant is long, it points to an obstructive process. And this makes sense because obstruction slows the expiratory phase. If the expiratory time constant is short, it points to an issue with compliance. This makes sense too, because poorly compliant lungs are stiff and cannot safely take much volume. Gas enters and exits the non-compliant lung quickly, producing a short expiratory time constant. Now that we are all enthusiasts of mechanical ventilation, let's take a step back to see how easy it is to use ASV. ASV has a few contraindications, therefore, most patients are candidates for its application. 3 types of patient circumstances present contraindications to ASV. These include patients with air leaks, such as bronchopleural fistula and open pneumothorax, won't work with ASV because it functions in a feedback-driven closed-loop design. Severe air leaks destabilize the system. For patients spontaneously breathing, neurogenic breathing patterns and irregular respiratory drives, such as Cheyne-Stokes respirations and Biot's breathing, shackle the ASV math and system logic. Why is an irregular respiratory drive a relative contraindication to ASV? If the patient is chemically paralyzed, an ataxic respiratory effort will not adversely affect ASV because the patient is apneic and the ventilator controls respirations. Therefore, ASV will function properly if the patient remains paralyzed. Finally, in chemically paralyzed patients with severe metabolic acidosis, ASV is an option, but exercise caution and monitor for and maintain the pre-intubation end-tidal CO2 carefully. Tidal volume in mechanical ventilation is based on ideal body weight. Therefore, on the standby screen, enter your patient's height and gender. This is a critical step that you must perform accurately. ASV is brilliant, but it does not know the patient's weight without your input. Percent minute volume equals a target minute ventilation. For healthy lungs, begin with an initial setting of 100%. For patients with lung disease, such as COPD, the initial percent minute volume is 120%. For patients with suspected metabolic acidosis and a pre-intubation end tidal CO2 less than 20, the initial percent minute volume is 180%. If the baseline end tidal CO2 is between 20 and 25, start with a percent minute volume of 160. If it hovers between 25 and 30, start with a 140% minute volume. PEEP and FiO2 are concepts that you are familiar with. For most patients, set the PEEP to 5 centimeters of water and the initial FiO2 to 100% and titrate the oxygen percent to maintain a saturation between 94 and 99%. Increase PEEP incrementally by 2 centimeters of water for unresolved hypoxemia despite an FiO2 at 100%. For patients with pulmonary edema, the initial PEEP is 10 centimeters of water. The maximum PEEP for any patient, according to the mechanical ventilation policy, is 15 centimeters of water. Adaptive support ventilation is an easy-to-use, closed-loop ventilation mode for safely managing intubated patients. With minimal user input, the ventilator can choose the most comfortable breathing pattern based on the patient's ideal body weight and lung mechanics. It aims to keep driving pressures and tidal volumes low for patients with normal and diseased lungs. The key to ASV's success lies in its real-time adaptability, which allows it to continually monitor patients and adapt ventilation parameters, promptly responding to patient conditions and potentially improving outcomes.